after that scrumptious, delicious food I'm sure everybody must have really enjoyed. So we proceed further with a very exciting quiz session. Incidentally, quiz, QUIZ, is Quick Uniform Intelligence Zone. So let's do some critical thinking and get into the habit of innovative learning today with this bingo housey quiz. The amount of good luck coming your way, okay, this is two things together. The amount of, the amount of good luck coming your way depends on your willingness to act. So your reflexes, your eye-hand coordination, your ear-hand coordination. So it's going to be all luck which is going to decide who is going to get the better prizes. But there are prizes for everybody here sitting in the audience who is really going to give the answers as well. So I call upon Dr. Sushant Mane, who is our quiz coordinator today, to explain you the rules of this little unique bingo quiz.
Yeah, good afternoon, everybody. And after lunch, we have to all gear up for this game so that, we are all excited to again continue the awesome sessions ahead. So the rules are very simple, as all of us have attended any quiz in our life. There will be one question which will be flashed. 10 seconds will be given to answer the question. It's a chorus answer because we want a discussion. But the punch here is the prize is initially not for the right answer. So we have a housey quiz. So what will happen is Dr. Nehal and Amruta are sitting there. They will pick up a random number. Then that particular number will be clicked. The question will appear. So you have all got the housey tickets in your this thing folder. So you have to take it out. It's not there. You have extra tickets?
Yes, we do have.
Yeah. So please take out the housey tickets. Whatever number is announced, you are supposed to put a tick on that number. Okay. So the person who completes the first housey row gets a prize. Yes. So the person who completes the first row first gets a prize. The second row gets a prize. The full housey gets a prize. So the prize is first who completes the housey. And number of people who get correct answers, we also have prizes for them. All these prizes will be given during the tea break at the console. Okay? Sorry?
Who doesn't have it?
No, sir, no Jaldi-fi, no corner. Only lines and full. And
Lines
we have
and-
two prizes per line.
Yeah, 2 prizes per line.
Somebody doesn't have
And
Two
two
prizes
full
per
houses. 8, 6 और 2.
So you
Horizontal.
have to hope that the number which is on your ticket, that question number is asked.
Is asked.
That is what you have to hope for.
Yeah. That is luck.
Again, whosoever is going to give the answers here from the audience.
They are also getting a prize. Two line and third line. Yes. And full housey. Yes. The prize is not for the correct answer. The prize is for the housey. So जिसका नंबर आया उसको आंसर भी नहीं पता है, फाइन, इट्स ओके. जिसका लाइन कंप्लीट हुआ वो खड़े रहने का वॉलंटियर नाम लेगा.
So delegates, even the numbers are going to be picked up here at random.
Yes.
All 30 numbers we have in a bowl.
Sorry.
So double blind.
हाँ.
She's going to just pick up a number and that is going to be like how we play house.
there will not be any false claims because we will have a team which is sitting and verify. They are keeping the records which numbers are being flashed. And 1,000 fine, as sir said, if anybody has.
Okay, one more thing because of the time constraints. Anybody who finishes the first row or whatever, second row, third row, will just raise the hand.
Yeah.
We have volunteers all over. So that
Yes,
person will
yes.
come there, from there, announce in the mic, cross-check the numbers. Me and Amruta will keep a tag, give your name. We'll write that. The prizes will be
In
given
the
in
tea
the tea
break.
break.
Yes.
Okay? नहीं, madam, उठ
Yes.
जाओ. हाँ.
No. He can continue. Yes.
He can continue,
नहीं,
he can
ticket नहीं
qualify
देख
for a
लेंगे.
full house.
Yes,
Or
you can
even
continue.
another line.
Yes.
टिकट नहीं लेंगे सर, सिर्फ
Ticket
वेरीफाई
नहीं
करने के
लेंगे,
लिए
ticket
टिकट
नहीं
लेंगे.
चलो. So we are
let's-
starting.
Shall we start?
Yes.
Everybody settle down. Everybody has their housey ticket in the hand.
Everybody settle down. Yeah. So Amruta, take out the first chit.
So Amruta is going to
Just
decide, huh,
wait,
the first
wait.
luck. Come on, Amruta.
Yeah.
Okay, so our first housey number is voting age number 18.
So 18.
1-8.
18.
So Sanjeevani madam.
So let's start.
Just tick it.
Let's start. In a child with biliary atresia, one can get any of the following ultrasound findings except
What is the answer?
Small-
You have to speak. Just speak. Sorry. Yeah. Yeah. 2. Yeah, that is the way to answer. Good, good.
Next number.
Tea break mein. Tea break. Next number.
Next number is number 5. Hum Paach. Number 5.
So this is the EEG which is shown. What is the diagnosis? SSP, cryptogenic West syndrome, myoclonic epilepsy and absence seizures. What is the answer? How many say 1? How many say 2? Flash the right answer please. The right answer is second. The right answer is second.
Yes.
Yes, yes.
Yes. Volunteers, please note down right the delegates giving
Yeah.
the right answer.
The next number.
Next number, what MS Dhoni hits in the last ball? Number 6.
6. Number 6. ये क्या हो गया? What is this? This is not a quiz.
the serology report of 4-year-old male child vaccinated for hepatitis B will show which of the following findings.
Come on, what is the answer? Yes. Yes, yes. Everybody is going to get a prize in the tea break. 1, 2, 3, 4. I am seeing. Yes. Except Amin. Amin knows the quiz. What is the right answer? Yes, it's 3. 3.
Dr. Sushant, you want to explain anything?
So it is an HBS AG. So I mean, it's self-explanatory. HBC is the core antigen which is not covered. So it is not there in the serology when you do. Yeah. Next number.
Okay, so next number is sweet 16.
16.
1, 6, 16.
The ideal agent for treating a fungal UTI is answer. Yes. Yes. The answer is 2. Answer is 2. Anybody nearing the line completion? No, still no. Nobody is nearing the line completion. We are already what? 6 questions down. 5.
4 questions down.
4 questions. 4
We
questions.
finished
down.
4 questions. I'm
Yes.
drawing the next.
Yeah.
Okay.
And the
One
highlighted
second.
ones
For
are
those who have
done.
missed, I will just repeat the 4 numbers which are done. It's
It's there on
there,
the
yeah,
it's
it's
there on the
already there.
screen.
Madam.
5, 6, 16 and 18. Yeah. Next.
You are mine, number 9.
Number 9.
Neonate presented with dyspnea
Any rows?
cyanosis. On X-ray, there are paratracheal soft shadows. The room air saturation is 89. Identify the heart
Yeah.
condition.
Why is the answer 3? Yes. So that is a snowman appearance or figure of 8. Right. Very good.
We are going to run out of prizes for the audience, I think.
Yeah, I think and run out of questions
अरे
also.
है
I
ना
think.
सर,
Next,
अभी इतना
next.
डेजर्ट खा के फिर थोड़े टाइम के बाद
Okay. Next number is Two Little Ducks, number 22.
22. So this is a 5-year-old boy visited the ER with complaint of fever, malaise, anorexia, headache and rash since 2 days. On inquiry, patient is found to be on antiretroviral. The next day, the patient developed cough and difficulty in breathing. Following picture was seen on the X-ray after 3 days. The child developed slurred speech, nystagmus and gait disturbances, that is neurological signs. Treatment of choice for the above condition is? What is the answer? Why? Yes. This is ART is the hint in the question. This is a fungal pneumonia which a CNS involvement. Flash the right answer. Yeah. So the
Madam ने
right
seriously
answer is
बोल
second,
दिया.
but the condition is a fungal infection. So the right answer is second.
Okay, can
Yeah,
we move
first
on?
corner.
Next number. 2 dozen number 24. 2 4
Number
24.
24.
Anybody for a line?
Arman, a 6-year-old boy, birth and developmentally normal, brought with facial twitching with numbness, tingling of face, right side focal convulsions, typically occurring at night with preserved consciousness during episode. What epilepsy syndrome is described above?
Who says one? Okay. Who says two? Now previously somebody said two, now they have changed to one. So
One is
right answer?
yes. So it's benign childhood epilepsy. Yes. Madam is leading.
Anybody
No number.
completed a line?
No luck.
Amruta, you need to shake that bowl, I think. Yeah.
Okay, next number is 2727.
27. A 4-month-old infant is being treated.
9.
4-month-old infant is being treated for severe bronchopneumonia for a few days. That is his blood gas. pH is 7.34. CO2 is 82. Bicarb is 44. Oxygenation is 69 and oxygen saturations are 84. What is the right acid-base disorder in this patient? Yes, that is the right answer.
Yes.
Second. So primary, it is a respiratory acidosis which is overcompensated by alkalosis.
नहीं सर ऐसा मत बोलो सर.
Next number. Lone Ranger number 1.
Number 1.
Line?
Line completed?
No.
No, horizontal line.
Only horizontal
We have to
line.
have horizontal line, not standing line.
A 3-year-old.
Sorry? No.
False alarm.
False alarm.
A 3-year-old girl presented with right knee, left ankle swelling for 3 months. After evaluation, she is diagnosed to have oligoarticular JIA. The one investigation that should be done amongst the following is
So swelling is at both joints at the same time.
so it is oligoarticular.
This is oligoarticular, no? Anti-CCP.
We have the diagnosis.
Cyclic citrullinated peptide.
Clinical diagnosis we have. Yes, Shikha is there.
So, click the right answer. The right answer is 2.
Yes.
Yes.
And why it is not 4?
45 to
Because
85%
anti-CCP,
patients
first of all, it
get
has no
that
role in
ANA
pediatric
positivity.
artery.
Yes.
Second, anti-CCP, if at all done, is for polyarticular.
Excellent. And why not ASO? Some people said ASO also. The
Diagnosis
clinical
oligo
picture
jai.
is not suggestive of an ASO. ASO generally we do in a rheumatic fever. Rheumatic fever, yeah. ANA.
Okay, so next number is 1 dozen number 12.
Number 12. Sorry? A 6-year-old boy presented with worsening of academic performance, inability to follow telephonic conversations and visual disturbances. MRI brain shows the following. What is it? So this is very easy. This is very easy. This is adrenoleukodystrophy. You can see the leukodystrophy in the MRI. And early scholastic backwardness. Yes. Next.
Okay, so next number is number 30. 3030. 3030.
You are done with the line. Please clapping for her. Shika, just cross check.
Please wait before
Yes.
clapping. Let us verify.
No, but she's excited, so we should clap and then we can come down.
See, number 30, 22,
Just check.
30, 22, 24, and 27.
Done,
Yes.
done.
Loud
Congratulations.
clap.
Third line.
Name.
Your name?
Likhil.
Dr.
No, they
Namrata.
can continue.
Yeah. Namrata.
Which
Dr.
line?
Namrata, ma'am. Third line.
Third
Line.
row. So third row is gone now. We
One
have
prize is gone. We have
one
2
prize.
prizes for the
So
third
we
line.
have
So
for-
there is one more prize for the
one
third
more
line.
prize for the third row. Naam.
Dr. Namrata.
Dr. Namrata. Full naam. Everybody wants to know the full naam and institution or place of practice. Nitin sir was asking. Say for everybody else.
Dr. Namrata Balwali from Hinduja Hospital.
So
Okay.
Yeah. So now coming to question, urine culture sample shows
This was the question which was left.
a colony count of 25,000 CFU.
Yes.
In which of the following sample it would be significant? For
Why
UTI?
3?
Yes.
Yes. So suprapubic is any aspiration, any count.
Next number, lucky number 7.
Good.
Wow.
Which line? First line.
First
Come
line
on.
done here.
Just stand up and
Here
read out
also.
your this thing. Yeah.
Dr. Shushan, 2 people. Here also
First
first
line?
line. First line.
First line. So we have
The
two first
numbers
line.
are 1, 9, 6 and 7.
And others are
That's
9.
right.
Yes.
Someone
First
else
line,
also
one
got
more.
the first line.
One prize is gone.
And second first line is there. Yeah.
First line.
Read out.
9, 7, 5 and 1.
9, 7, 5 and 1.
Please. I
Five
mean,
हो गया.
it's there, na? Clap hands.
5
Your
हो
name-
गया, 5 हो गया.
Your names.
I'm Deepa Bhandarkar.
And
Prajakta Kadam.
yes. Loud of applause, please. यहाँ 2 जन है. Per line 2. First line is gone.
First
हाँ.
and third
Now we
are
have
gone.
second line,
Only
2
second.
prizes, and third line, 1 prize which is left, and full housey. Yeah. All of the following are predictors of poor prognosis in Kawasaki's except. What is the answer? Neutrophilia. Anybody else? 3. Anybody else? Anybody else? सब हो गए. Flash the right answer. Its answer is thrombocytosis because it is one of the diagnostic criteria. It is not a poor prognostic factor.
Thrombocytopenia in the first
Pneumonia,
week is
yes,
a poor prognostic
Is a poor
factor.
prognostic factor. Except hai. The question is except. So if the yeah. Next number. Ah. Next number.
Next number is number 8.
Number 8.
So identify the ECG abnormality. Second degree heart block, Mobitz type 2. Second degree heart block, type 1. First degree heart block or complete heart block.
No answer. Yes. So we have a right answer. Mobitz type 2.
Yes.
Yes.
Because
And
the
here
PR,
also.
PR
Yes.
and this thing will be RR interval will be constant.
Yes.
Okay.
Yes.
Okay, next number is Valentine's Day number 14. 1, 4, 14.
Anybody with a line? No. 8-year-old female child was brought to the emergency with hematemesis. Past history of 1 episode of hematemesis 6 months back. After stabilization, she has mild pallor, no icterus, no lymphadenopathy, splenomegaly grade 2. What is the probable diagnosis? This is again very easy. Yes. So it is extrahepatic portal venous obstruction. Why this is not ITP? Why this is not ITP? Yes. They said splenomegaly.
They
So
said.
splenomegaly is a factor which goes against ITP.
Can we move on?
Yes.
Next number is danger number 13. 1, 3, 13.
A 3-year-old child brought with parents in emergency with alleged history of ingestion of button battery. On X-ray, battery is found in esophagus.
So this is a full house 1. There is no discrepancy in the answer.
Yes.
Can we wait for it to pass in the stools?
No.
Yeah. So it has a risk of exploding. Right. Next question.
Everybody is competing for the full house.
Next
here.
number is number 21. 2, 1, 21.
Which wait. Last line. आपका कौन सा है? ये तो टाई हो गया, आप क्या करना है?
How many are there?
3.
See, okay.
Wait.
इन्होंने पहले
Yours
हाथ ऊपर
is?
किया था. He has raised his hand first.
Yeah, he has
Then
raised
after
his
that
hand
she
first
did.
and then
Yes.
her, ना? हाँ. Confirm the number. Extra prize मिल जाएगा. हाँ.
With sir's permission,
So
sir.
we have a suggestion here.
2 or we can
We have
give
a
the
suggestion.
second one later on.
देखो 3 जन है ना, एक को ओपी गाई दो पढ़ने को, एक को नेल्सन दो। और फिर भी किसको और चाहिए तो मेरे पास नाथन ऑस्की है हेमेटोलॉजी का।
Another option from Vipin sir, we can have lunch again. Okay, with the dessert.
Okay. I'll read out the numbers.
Yes.
22, 21, 27 and 30.
30.
So we will give, so
Read again. Wait. Read again.
silence. हाँ.
हाँ.
22, 21, 27 and 30. 30.
Yes.
My God.
एक मिनट इधर से बोलना, किसने पहले बोला?
इधर से है.
हाँ तो बोल.
21, 22, 27, 30.
अरे जो चौथा तीसरा लाइन है उसके लिए पिज्जो है ऑन्कोलॉजी का बुक।
This is also same. 21, 22, 27, 30.
नाम.
श्रीराम हिंदुजा हॉस्पिटल.
Ma'am, Dr. Harvinder.
चलो.
डॉक्टर हरविंदर फ्रॉम होली फैमिली हॉस्पिटल।
या ये इनका भी है.
Sir has been generous to grant an extra
prize. Yeah.
So he will get it maybe later on.
So here also
whosoever
we have
is-
same numbers. 22, 21, 27, 30. तो सबका है.
और एक है वो पहले से।
Yes. Come on.
Okay,
next
moving
number.
on, next number.
He had got it first.
Next number is number 11.
21 हो गया. Next 11. हाँ.
The last number called out is number 11 right now.
Okay. So yeah. Wait. We will complete the question first and then you read out.
Second line.
Yeah. Wait.
Just
Shika.
wait. Let's finish the question
Yeah.
first.
An asymptomatic adolescent male, normal physical examination, noted to have hematuria on clean cast sample during a routine urine examination. For fitness for sports, choose the following next step. Repeat urine routine after 2 weeks, urine culture, spot sample for urine calcium create ratio, family screening.
Repeat urine after 2 weeks. How many say 1? How many say 3? 3 is the right answer actually. Okay, madam, can you explain?
Yeah, see, actually in adults it is common, but the kids, they can have calcium by. It's done, 3 already done.
No, it is not disqualified. So
Pankaj is not here, but I have confirmed the answer with Pankaj,
3,
so no
yeah.
disqualification.
So we had a line completion.
We have here.
Yeah.
Three
Line
people.
2. Line 2.
Wow, there are 3 people who
3
have completed.
people on line 2.
Line 2. Numbers are 18, 13, 16, 11.
Yes, that's right.
Just once again.
हाँ,
Name
मैं
is
बोलता हूँ बाद में.
Dr.
Liver का था ना?
Poonam Wade. Second is yours, sir.
Clap hands please. जिनको नहीं मिला वो भी clap कर
Second
सकते
is
हैं.
12, 11, 16, 14.
14. Yes.
Yes, that's
Dr. Devangsha from Borivali.
Devansha.
And
Dr.
third
Devansha.
is 16, 18, 13, 11.
16, 18, 13, 11. That's right.
Yeah.
Dr. Raksha
Next.
Kate. Dr. Raksha.
Next, Amruta.
So now we have only
Now
full
we
house.
are done with all the rows, huh? Khatam.
Now only
housey.
full houses.
Full housey. Yeah.
So first, second, madam, third, Tantan.
Third also.
Instead
हो
of
गया.
two, we are giving
सबके
out
सबके extra दिए.
housey.
Full housey now.
Okay, next number is number 25.
All of the following local drugs can be used in this condition except. Yes. There is an except in the question. It's very easy. Ivermectin is not local. It is a oral. It is a oral preparation. Yeah. It's local except. All are local. Ivermectin is oral. That is the hint in the question. Ulta question hai, right? It's an ulta question.
Next number is number 23.
Special prize, ma'am.
Anybody for full house?
Ma'am.
A child is diagnosed with vitamin D deficiency rickets on the basis of abnormal calcium, phosphorus, alkaline phosphatase, vitamin D. On successful treatment, which of the following will normalize first?
Three is not the right answer.
Yes.
2, I think.
So
Right answer is second.
phosphorus. Yeah, second. So six.
Okay.
Next question.
Next question. Number 3.
Third. Anybody with a full housey? A 5-year-old child is diagnosed as IgA vasculitis, commonly known as Henoch-Schönlein purpura. One test to confirm the diagnosis is. What is the confirmatory test? What is the confirmatory test? Sorry? And? Yeah. Answer. Yes, it's skin biopsy. Skin biopsy. We have to do a
Okay,
skin
next number is last of teens, number 19.
Full housey.
biopsy. Full housey.
So we have first full house. Let us confirm the numbers
There is
first.
only one prize na, for first full house.
Two
Do hai.
prizes. Two full houses. Two full houses.
She said 29, right? So this is a false alarm, this one.
Acha, no. False alarm, false alarm.
False alarm.
We still have 2 prizes for full housey.
Fine, ha.
नहीं बाकी है.
Dr. Amruta.
Next,
Yeah.
next number.
Next number.
Next number is number 17. 17.
17. Boss, 17. नहीं. Ma'am,
Question.
A child with celiac disease can eat all of the.
what was the
following
19th question?
except-
हो गया ना? HSP ना?
Hello.
I'll just see.
Question.
Yes.
Question.
Answer is 4. Answer is 4. Yes.
Yes. Next number 2. Yay.
Yeah, full housey. Though we have 2 full houses. Wait.
So
Let
we
us confirm.
finished it.
she was.
Let us confirm.
Just read out the numbers.
We have 3, huh?
I'll
Wait,
read out
wait,
the
wait.
numbers.
And then we discuss the question. नहीं आएगा. Question वापिस करो ना भैया. हाँ पहले numbers करते हैं ठीक है.
8.
हाँ.
So the number is 8, 6, 2, 3.
8 गया.
8 गया. हाँ.
13, 18, 11, 19, 22, 21, 27, 30.
Very good.
Very good. Your name.
Congratulations.
Dr. Jagruti Sanghvi.
There are 2 more. There are 2 more.
There's
Dr.
one more full
Sushant.
house, I think.
9.
There are 2 more.
Yeah.
Full housey.
Ni-
Shall I?
19.
5, 7.
Marathon.
Dr. Nehal. 5, 7, 2, 6, 11, 16, 18, 12, 24, 22, 30, 21.
Yes.
That's right.
Yes.
Jagriti
है ना?
madam,
Dr. Arvind.
19 is not done.
Dr. Arvind from Kalina. Arvind.
19,
Arvind.
19 हो गया है.
Done, it's done.
19 is
That
done.
was the last question.
That was the last question. You can show question number 19. Yeah. We will stop. This was not clicked.
There is one more.
But the number was called out.
I think I know.
नहीं वो उसके बाद का था सीबी नेट का ना. 19 was announced na number.
Yes.
19
It was the last number. I said last of teens 19.
Yes.
19 was announced.
So we stop right?
We did go back.
They want to discuss number 19.
Yes.
Yeah. Madam.
An asymptomatic child is incidentally found to have extremely deranged PTT. Reconfirm which clotting factor deficiency can be suffering from.
It is incident.
Yes.
12. That I think 12.
Yeah,
12.
asymptomatic.
12 doesn't bleed.
Asymptomatic child. So,
Yes. Yes.
I hope everybody enjoyed. All the audience
Right.
is going
Thank
to
you,
get
thank you
right
very much.
answers.
Enjoyed.
Okay, so we
Shan
move
bacha
on
hai
to the
kya?
next session. The next scientific session is a hybrid session. It's partly physical and partly virtual on COVID and rabies
thank you
vaccine.
all.
On COVID and rabies vaccines. The expert for this session would be our vaccine expert, Dr. Vijay Yevle sir, who's doing it on a virtual platform. And with him is Dr. Amruta Shirodkar and Dr. Grivita Raikar as moderators.
Yeah, hello sir. Sir, just unmute yourself.
Sir, unmute yourself.
Sir, unmute yourself. 1 second, sir.
Can you hear me now? Very good
Yes,
afternoon.
yes, we can hear you now, sir.
Good afternoon, Rajesh. Good afternoon, Ambedkar sir. Good afternoon, Madam Mulani. I can see you all.
Nice to see you online though.
Yeah. I'm missing Mumbai conference, but
Sir, we are just loading the PPT, just starting in a minute.
no problems.
Yes. Sir, our first question is 9-year-old there was no bleeding. Sir, brought the would be you observe the dog. Give the child 47. Advise only low. Give the child start. Yes. Okay. Wow. Okay. So we have will people
think that let the
It never happened if someone has taken 14 days dose. So that means the fourth dose is actually super dose. So you can combine those last two doses and one maybe 14 to 28. But because of the medical reason, I would give the option 4.
But even if
But then if you give 4 doses, that should be valid, right? Yes. So here patient has come after day 7 of diet. So you take this as day 0, day 7 of the injection.
0. So
So the day we start the schedule will be day 0 of the injection. I pass it on to the medicine or expert on this.
I did not see who was speaking, but I believe it is Nitish. I absolutely agree with what he has said. So, there is scientifically the animal studies, they have a long-term follow-up also, and the fifth dose is really super dose. What we must understand, we must try and categorize the drugs. For all activity purposes, patients who come to us, they are category 3. Even if there is a small drop of blood, it becomes category. That should be removed. Here is a scratch, and there is no, go back to the previous state. So there is no blood. So this becomes category 2. So passive prophylaxis is not eligible. And as it is said, this is the national body has not recommended, not adopted this 4 procedure. Either which will be, even though it will not be incorrect if you give the second option, but very clearly today, unless national changes the schedule, I able to the 5 dose and it is all related to overdo rather than protecting as well.
Sir, I have a query. In case we are thinking of giving a 4-dose schedule, then is it worthwhile to give the last dose on day 28 instead of any time between 14 and 28, so that we can monitor us even as a pre-exposure prophylaxis or ready to cover for that?
Two things that I like to say. First and foremost, whether we do it from day 14 or day 28, adequacy and longevity of the antibody response doesn't change. Number 2, the pre-exposure prophylaxis is no longer even 3 doses. Because now there is a recommendation that there could be only 2 doses, day 0 and day 3. Day 0 and day 7. So there is no point in giving the 4th dose if you are trying to make it a pre-exposure prophylaxis. In the past, there was a concept that you observe the dog or the animal for 10 days, and if in the end of the animal doesn't develop or doesn't die, unlikely that the animal is treated. And then we could, there is to be practice of, which was probably incorrect, of converting this so-called initiated post-exposure prophylaxis into pre-exposure. But that doesn't hold waters now. So you either give a full post-exposure prophylaxis or use 2 doses as per WHO schedule or 3 doses as per national schedule for pre-exposure prophylaxis.
So, if the government set up, they give 4 doses, that is 0, 3, 7 and 28. But they give it as a substitute instead of intramuscular. So how do we justify it?
Not the substitute, it is the intradermal dose that is given the government setup. So I would say what is really immunological and scientifically proven that we use intradermal or intramuscular. The viral antibody research are adequate and long lasting. So you save on the antigen content or the vaccine content. You can use inject multiple vaccines in the given vial. But this is actually in the government setup where one you have number of patients accumulated on the given day. Number 2, you intradermal vaccines injection, which is not very easy. Of course, we as pediatricians, many of us used to give BCG vaccine in the past. But my view, if you give a fractional dose intramuscularly, we are not bound for the very good robust antibody titers.
A question, please. So clearly you specified 17 days ago. So if the parent comes and says, 2 हफ्ता पहले कुत्ता काटा था, does it change?
It really doesn't change. We put this 3 days because, as I said, 10 days of the onset. But the return is at first presentation. You give the dose, regardless of the time that is the
One second. Vaccine 100% safe.
Yes. The new generation vaccines are absolutely safe.
So just to add, how long can you give the vaccine to a patient on delay? Suppose someone is at doctor 5 years back, should you give vaccine now? So clearly, practically, is no longer any vaccination started beyond 1 month is the last dose. The efficacy is questionable. If the fellow doesn't, maybe these people never needed the vaccine. So, 1 month you must actively promote starting the vaccination. There is no question about it.
This is important actually because many times children hide this history from the parents. Just for the fear of getting scolding from the parent, they don't tell on the working time that there has been a dog bite or they have had a little mischief, and so it's very important to realize this.
Sir, the government has not changed the recommendation of 5 doses and in government sector 4 doses are given. So it is contradicting to their own policy.
What is your take on this? I'm not sure whether that in 4 or 5. I believe more so. It really isn't 5 doses.
Rabies sector in the there is no question. Non-rabies sector, government sector, categories of the medical officers category 4 or 5. Both are category, but it's supposed to be 4. They are liable for the action, right? You will allow for your action to be 4 doses. I would insist that private practitioners don't actually 1 dose. Give 5 doses to the population change in the government policy. Sir, many of families are having dog in their home, and the infants when they come for regular vaccination, they ask about the rabies vaccine also. So should we actively promote that?
Yes, not only should we promote vaccination of the pet annual vaccination, but we should also offer free exposure prophylaxis to such child.
Okay,
Okay, we move on now. This is already covered. This is about the category 2 exposure and what needs to be done is very well discussed. Our second case scenario now, the same child, 7 years ago, the child was 2 years old, was given 5 doses of rabies vaccine as he had a history of scratch by dog at that time too. Now, what would be your management if this was the case scenario? You only 2 doses of vaccine not made environmentally. Repeat the complete schedule with 4 doses. Do rabies antibody titer and decide the need for vaccination. Can we start the voting basically vote on the voting pads? Please vote music please.
Okay,
so most of the audience, 60% voted to repeat the complete schedule with 4 doses on day 037 to 28.
who has
Who has voted for repeat? Most of you. Anybody wants to say? So I think we'll dedicate to sir. And yeah, sir.
Yeah, so any child who has received full post-exposure prophylaxis in the past, the validity or effectiveness of protection against rabies lasts only for 3 months. However, if a child with the time lasts more than 3 months, you don't have to repeat the entire schedule. Only 2 doses are enough. And the correct answer is option 1. What this child would need will be 2 doses on day 0 and day 3. So what is referred to as re-exposure prophylaxis.
So re-exposure lifelong. We have previously documented written pre-exposure or post-exposure is only 2 doses. Right? If you took say 1 year of a rabies vaccine and 62 develop back again, you take only 2 doses. Because there is an energetic response. What if it's 4 doses? Yes.
Total dose is 0, 3, 7, 14 to 28 days. Evaluate exposure prophylaxis.
Sir, no need for the immunoglobulin antibodies to suppose this particular episode had a category 3, right?
No need.
No need.
No need.
We are coming to the question on monoclonal antibodies. Yes, hang on. Coming to the question. Okay, so this is clear. Any amount of time in the labs after the complete schedule.
Valid point from Dr. Bhatt. This is true for only modern tissue culture vaccine. Someone took those old animal it's not recommended. Only for the current vaccines we are using. Like some of us who have taken those injection, 14 injection, or 14 injection, that's not valid. If the dog is vaccinated also.
Yes.
So if the
So if the dog is vaccinated, one should be still give the prophylaxis.
Vaccine failure can occur both in human beings and animals also. And it does not, and this is something which is fatal. So, and it must go rather than adult.
The animal vaccines have efficacy at best of 50%. What about and the criminal, community pet moti can become here tomorrow and vice versa. So they are observed the dog.
So
in this case, the patient had taken all 4 doses. Now, in case patient had received only the PA exposure prophylaxis, then again the same 0 doses she will also from.
Yes, even in the exposure, what is obviously in need of passive prophylaxis. Otherwise, the schedule doesn't change.
Only 2 doses in that case.
Yes.
Following up the exposure, the would repair those. Only thing is you don't use passive prophylaxis in this check.
I think let me clarify. If anyone has taken documented modern tissue culture pre-exposure complete course or post-exposure complete course, just say 2, 4 doses 5. Another exposure beyond 3 months, there is only 2 doses lifelong.
Sir,
One more, sir. Yes, sir.
if by chance
that patient becomes immunocompromised, what will be the immunocompromised? Every time you will receive monoclonal antibody. And I would prefer give 5 doses post exposure in a immunocompromised versus 4 doses.
That's the same category to reduce exposure in the immunocompromised forms of monoclonal antibody as well.
The important thing that remember that
Yes.
the passive protein now that monoclonal antibodies are free. In the past, there was scarcity of the human immunoglobulin. So the rabies prophylaxis would deal with the vaccine and the passive prophylaxis used to be available later. So remember, beyond 7 days of the first dose of vaccine, one must avoid using passive prophylaxis. There is no clear guideline, but one of the experts on the what he recommends is suppose the child has received 1 dose of rabies vaccine on day 0, second dose on day 3, and your rabies immunoglobulin is made available on day 7. Administer that immunoglobulin on day 7, but you restart your vaccine prophylaxis from that day, taking that day as a day 0.
What about other animals, cat and mice and wild animals?
Domestic animals, not cat like yes, you require AAV, but others like rabbit and they don't require rabies vaccination. Similarly, domestic rat would not, but all the jungle rats and those who are from the forest.
Yeah. So we will reveal more about the case scenario regarding reducing immunoglobulin or monoclonal antibodies, which of the following is not true. It should be given to all class C bites by suspected rabid animal. It is not required that the patient has received a complete course of PEP or PRP previously. It can be given from the 11 days after the first dose of the rabies vaccine. Half the dose should be given intramuscularly.
Please vote.
Please vote. I think the audience are unanimous here. So,
very learned audience.
So I think more than 90% have voted for option 4. Half the dose should be given intramuscularly. It is a wrong answer. It is not true. Over to you, sir.
It is no other practice. In fact, it has interference with antibody response, and practice which was recommended in the past is no longer valid. So you discard if there is an excess, if there is less, you add, you dilute it and use it.
Right. We'll just move on. This is a British position paper on the Ladies 2018. I think most of this are already covered. There is a second point in the previous question that if the patient has previously received a complete course of prophylaxis, immunotherapy and monoclonal antibody is not indicated. So this is indicated. This is the British position paper 2018. Move on to the next slide. We have small effects on the ladies vaccine. That's not that I think sir already answered. There's one myth proposed prophylaxis that provides the pet dogs. Yes. If the child has fever on day 3, should we give the vaccine dose or withhold it, sir?
Fever is no problem. Ladies prophylaxis is the most important thing.
Absolutely. So there's not a contraindication to giving the vaccine. Now we have all exotic pets like rabbits and tortoises.
Most of these domestic pets do not require antibiotics prophylaxis unless they are from the general.
Are the pets in the reality?
I'm not too sure. I think all these pets given in rabbits and tortoises.
Only dog and cats. When if you horses and animals, yes, we will give them. So there was a question asked to me that if you ever bite by an elephant, you will take this vaccine. SPL is provided to survive.
Okay,
I can hand over to Vibha for conducting the rest of the day. Moving on next, 12-year-old Neeraj had just recovered from MISC. A follow-up with the seed reduction, his anxious parents asked the doctor, when should they take the COVID vaccine? What, as per their pediatrician, would be the most likely answer? No need to vaccinate the child is already immune, in fact, immune. After 30 days of recovery, after 90 days of recovery, and after 6 months of recovery. Voting lines. Please vote. Yes, the audience is rightly answered after 90 days of recovery. Sir, your expert comments on this?
Yeah, so there is no robust evidence of full protection after natural infection or exposure, and hence it is recommended that vaccines is given. Well, immunologically or scientifically, as soon as the individual recovers of the vaccine, the 14 days when the effective period is over, technically can be waited. But for logistics and purpose, the government of India had recommended to wait for 3 months. And in these 3 months, it is very, very unlikely that the infected individual will have reinfection. So there is to be a history of shortage of vaccine, and for that reason they had recommended. But even today, the recommendation is to wait for 3 months. We hope that since the risk of reinfection within 3 months is absolutely minimal.
Thank you, sir. Moving on next. 13-month-old Isha was admitted to MISC and received IAP. Now she's 15 months and due for the MMR and varicella vaccine. When can she be given? Now, since 2 months are over after IAP, 6 months after IAP, 8 months from the last dose of IAP, and live vaccine should never be given. Should not be given to her. Please vote. Please start voting. Sir, the right answer.
the right answer would be 18 months, but it all depends on the dose of IAP that is being used. There is a definite evidence that varicella immunity is suppressed if you use it within the 11 months of having the high dose. 2 is the dose that is used for treatment of MISC. So one would wait for 11 months. However, MMR can be given a little early. And if the child has received about 300 to 400 per kg, here is the table that you have projected. It's very clear, and these are the standard recommendations made because this passive immunoglobulins do interfere with immune response, especially when the live vaccine is given. And MMR and varicella both are live vaccines. So this recommended rule is better to follow those in Europe.
I think it's simple to remember. Why don't you give remember varicella over before 9 months? Because there are transcription antibodies which prevent vaccine uptake. So ideally is to wait till 12 months. Same way IAP is a very high dose of this antibody because all the donors are exposed to these two diseases. So you don't before 9 to 12 months. Very easy to remember, don't have to memorize. When we give the other vaccination, the vaccine, all key vaccine can be given, no live vaccine. Like live A, only yellow fever can be given. And then you answer why yellow fever you can give after IAP. Because the donors don't have antibody against the vaccine.
The last other vaccines can be given with the just you can combine as many vaccines as you wish. But I believe there is nothing urgent. Always wait.
Moving on next, 13-year-old Divya has just been discharged from the hospital after treatment with H1N1 type A at RTI. She is due for both the flu as well as the COVID vaccines. What would be the most appropriate advice given? Both the vaccines should be co-administered after 2 weeks. Can we give COVID vaccine first and after 2 weeks followed by the flu vaccine a month later? You can give only COVID vaccine after 3 months, only to give the flu vaccine for this season. Honestly, it's good. The poll, please. Yes, as rightly said, both 1 and 2 would be correct. Sir, would you please comment?
Yeah, so one thing is natural infection in the H1N1 would not prevent reinfection or infection by other subtypes of the influenza virus. So this child would definitely require influenza vaccine. The fact that this 13-year-old child contracted admissible required hospitalization for influenza must be maybe having some comorbid. So this child would require annual vaccination. And on the privilege to experience protection. Now, as I said, as a policy, the government of India recommends to wait for 3 months after COVID infection. There is no such recommendations for influenza, and these vaccines can be co-administered. In the past, it was recommended not to administer any other vaccine along with COVID vaccine because these vaccines were not very extensively studied for their adverse events or so the what was recommended was to use COVID vaccine, have a gap of at least 4 weeks or 1 month, and then use other vaccines. So the recommendation has not changed, but as I said, immunologically,
Is it restricted? So probably you are looking at the mortality and morbidity of flu in this age group and looking at the immunology of biology infections. When immunity plays major role than the vaccination in many infections. Is it rational practice to give 13-year-old vaccine by a separate term and recover recently?
So that is what I said, that influenza can lead to complicated illness in children who are chronic diseases. This child has recently contacted LRTI following H1N1, which required hospitalization. So most probably there could be some underlying chronic disease or immunoglobulin condition, and hence she would, and after having the hospital, one's parents could obviously offer another protection against flu, maybe for lifetime. So scary experience for parents, and it's a safe vaccine which is available. In fact, if you look at the protection, it is well studied in older individuals than young children. So the antibody response is good. If based on the match. If there is a good match with the university produced, the vaccine is manufactured based on the base that is made from surveillance data, the most likely strain that is likely to circulate. And if there is a good match, the influenza vaccines are very effective.
Sir, just referring to your point, can you just one question? Referring to your point that COVID vaccines are not to be given with one vaccine, we are a step ahead and we have got bivalent vaccines now. We are combining flu and COVID vaccines. It's already there in the market.
Is it? I'm not aware of this.
Yes, the Moderna company has come up with its first batch of bivalent vaccine.
I believe that bivalent vaccine is the original one, COVID vaccine and the vaccine that is variant Omicron variant. It's not bivalent.
No, it's Omicron with H1N1. Madam, we already done a short. We have the next question. You can monitor to just say the question.
No voting.
No voting, no voting.
Okay, so what
is most potential risk to adults and girls of taking adenoviral vaccine? Vaccine-induced TBP, pericarditis, myocarditis, or post-vaccine disease. So,
the audience
agrees on this number one is the right option. And we have the next slide. Just have a few activities that we already covered most of that. If the child has suffered from COVID, does he or she still need the vaccine? Yes.
Well, children are reservoir for the virus, and not at all children come out with asymptomatic disease. There is a risk of NIC. Then secondly, children who are comorbidities can really end up with very complicated illness, and especially the adolescent children can behave like adults and have severe pulmonary disease. So children do require vaccine.
Do we need to take the COVID vaccine every year?
It's too early to comment on this. Maybe with only time, but it appears that the celebrated immunity is reduced by natural infection and whatever vaccines which are based on the original strain. The celebrated immunity is good enough to prevent severe disease of that. So, as an antibody titer sustained over a period of time, it may not prevent infection. However, the child or the individual is protected against severe disease. So it's difficult to answer at this point of time whether it will be flu annual vaccine every year.
Will the present COVID vaccine work on the various mutant strains as well?
I think I partly answered this. The children
Do we make this is already answered. As preferred, which would you prefer vax, Corbevax, Covovax, or vaccine as it's all already question in our OPDs?
proteins will invest vaccine and obviously protein will serve in vaccine. Corbevax and Covax. Covax is little better because Covax has made from the S protein, whereas Covax has the entire S protein, whereas Covax from the RBD. And Covaxin is inactivated vaccine. So inactive vaccine is also good. In fact, there are trials conducted in our country, and this vaccine is used and has proven to be really effective. But obviously, certain vaccine is it's a very safe vaccine and highly immunogenic also.
Thank you, sir. Thank you so much, ladies and sir, for the possible very time. Thank you.
Thank you.
Absolutely. Thank you, sir.
I must compliment you very well.
Thank you, sir.
Thank you, sir.
The
The term medical legal refers to both medicine and law.
To understand
To understand the application of medical and scientific concepts as evidences in a legal case.
we have the next very interesting session, case scenarios in medical legal issues, where the expert is Dr. Bela Verma, madam, and we have moderators Dr. Amin Kaba and Dr. Satish Shahane.
Hello. Hope so this session की ज़रूरत नहीं पड़ती, but medical legal things are very important now, and I think we should pay little attention more because sometimes you have to leave all open and go. In these cases, we are stuck in. So these are the important issues to discuss about the medical legal, and I invite Dr. Amin Kaba to start the session.
I hope everyone's still awake. Okay. 4-year-old male child, known case of cerebral palsy, known case of birth asphyxia with malnutrition, brought with history of fever since 7 days, breathing difficulties since 3 days. Examination while quite a toxic child, cold extremities, saturation 85%, bleeding from prick sites, nose and mouth, heart rate 80 per minute, gasping, BP not recordable. Did the routine management. Child was still oozing from every side and died in 3 days after admission. Next slide. What is the immediate cause of death? Start voting. DIC, acute bronchopneumonia, acute cardiorespiratory arrest, or SAM?
Start voting. So this is important to fill the death certificate.
Wow.
Oh.
So we have
Sir.
acute cardiorespiratory arrest. Anyone who's not written cardiorespiratory arrest, can they say that? Why not acute cardiorespiratory arrest? Especially residents. Most of the certificate has that, right? Lovely, lovely. Can we have the next? We'll see a certificate.
So actually, we are seeing since morning, we have such an enlightened and intelligent audience. So that is the right answer. We'll just have a look. Now this is what a death certificate looks like, and it is issued by the Ministry of Home Affairs from the Government of India. And this is a legal document, and every one of us should know how to fill the death certificate properly. So it has two parts. The upper part is a detachable part. So that is, I don't know where the light is going. It's not visible. So the lower part is a detachable part, which is given to the relative, and the upper part is sent to a copy of it is sent to the registrar. So there is, under the Registration of Birth and Deaths Act of 1969, every death has to be certified properly because it is tabulated by the registrar and sent to the chief registrar by the 10th of every month. So what happens is, most of the people do not know how to fill the death certificate properly. So we'll have a look. Even here it is written cardiopulmonary arrest as the first. That is a wrong way of writing it. So as we see, the death certificate has two clauses, 1 and 2. One has A and B. So a single line has to be written in A and B. It has to be a legible handwriting with no abbreviations of any disease. It has to be full form. Now the immediate cause of death is a morbid event that led to the immediate cause of death. So it will be the disease, injury or complication. So in this case, it was a disseminated intravascular coagulation. The antecedent cause or the underlying cause is the event or disease that started the train of morbid events between normal health and the immediate cause of death. So here it was bronchopneumonia. And the part 2 are the significant contributing other morbid conditions which may not be related to the disease per se, but have some unfavorable outcome for the disease or the death. So here it is cerebral palsy with severe acute malnutrition. So that is the way it has to be written. Also, the diseases are classified, coded and grouped as per the 10th revision of the ICD, or the International Classification of Diseases, which is recommended by WHO. So it's an entire book of coding, and that is how we should be coding, because that is useful in the health surveys and the other health protocols which are issued by the Government of India for the diseases. So this is the right answer. Therefore, cardiorespiratory arrest is not an immediate cause of death. The immediate cause is the disease, injury, complication which caused the death and not the mode of writing. Our residents even write type 1 respiratory arrest, cardiorespiratory arrest. No amount of teaching makes them change that. Enroll for a course on certification. There's a whole manual for physicians where there is this certification, 100 pages book also, and also available on the online where you can learn about it. Now coming to case 2.
Yeah. So this is a 6-year-old male child who was brought quite bad, GCS of 3/15 after a road traffic accident. The CT was suggestive of an intracerebral bleed with multiple skull fractures. Vitals were just about maintained with inotropic support and ventilator. The pupils were dilated, not reacting to light. Please read the criteria carefully to certify brain death. You can start voting. It will take a little bit of time. I won't read it out, it's a little complicated. Read them carefully. Yeah.
Well,
we
at
have
least 35% people have answered it rightly. So now let us see what is brain death. So the awareness regarding brain death is extremely low in India. But we must know how to certify brain death because of its relevance to organ donation and the legalities which are associated with it. So the Transplantation of Human Organs Act of 1994 has been amended now in 2014, and it is called the Transplantation of Human Organs and Tissues Act. And under this act, there is an entire form that has to be filled. At least 4 people are required to certify a brain death. And 3 important criteria are there for assessment and declaring a patient death. So one is all criteria which fulfill that there is irreversible brain coma. So there is irreversible coma. Second is all the brainstem reflexes are absent. And third is the apnea test is positive. And these tests are done 6 hours apart. So twice you certify and check whether the patient is alive or not. I will not go into details of this criteria, but it would be worthwhile if all of us could read it. Not all institutions have organ transplant facilities, but yet if you wish to that some patient has willed and wants to donate, then we have to tell the zonal transplantation center, the coordination committee, so that it can be retrieved before the patient is put off the ventilator. So the right answer is the first one, that is core temperature should be more than 35. So it has to be at least 36 and above. The pupils are fixed, not reacting to light. The apnea test is positive. So what we had put up a part of the criteria, not all the criteria. So these are some of the brain function tests. So I told you 3 things: brain coma, complete coma. Second is brainstem reflexes are absent, and third is apnea test. So each one has to be described and you can read about it. So this is how you would do it, and all these are the things which are to be fulfilled, and then only you can declare that the patient is brain dead. This is a form 10 which has to be filled in case you have to donate the organs, and at least 4 people have to sign it and check the patient 4 hours apart. Therefore, the take-home messages would be that brain death certification committee is mandatory. Minimum 4 people are required to certify the brainstem death, at least 2 examinations 6 hours apart, and if you have to retrieve the organs, and these are the organs that can be donated. That is heart, lung, kidney, liver, pancreas, cornea, eyeball, skin, bones, and heart valves. Okay? So we come to the case third.
This is the common, like we get maximum patient in the evening time, and 3-year-old female child is brought to your busy OPD at 8 p.m. with the history of discomfort in the genital area. And on examination, you have seen some evidence of trauma and vaginal tear. And then further inquiry, you revealed that there is a parent suspect and uncle has sexually abused a child in the morning. So what will be the next your plan? So you leave the parents want to leave the OPD because they have this discussion, they want to just take back the words now, and then they allow them to leave because you have got 20% to waiting outside and you are busy. Second is you first aid management and send them to the surgeon because you don't feel guilty because it is not your cup of tea anyway. Inform the police immediately and take the details of the child and parents. And parents are insisting that you hide the issue, they don't want to inform to anyone. You also don't inform, and then nothing will happen to you in the future. So what will be your future plan? Starts. So I
Yes.
think
That's
your-
an
yeah,
excellent
excellent
answer.
because even though you are busy, you take the time out because this is the important thing. Because if you don't inform, it is a medical legal implication because you can be jailed.
So just the way Pankaj was doing in the morning, suppose you remove that line, further inquiry reveals that parents suspect an uncle has sexually abused the child in the morning. Suppose the history is not given, then what will you vote for?
Same.
Excellent.
Yes.
So any trauma has to be
Yes.
verified and informed.
So this
Please, Yoshi.
comes under the POXO Act, which was amended in 2019, which is protection of children from sexual offences. It addresses all children up to the age of 18 years. It's a gender neutral act. So it can be a boy or a girl, and one has to notify it. It's a notifiable offense, and otherwise it is a punishable to the person who knows it and hides the fact. So it addresses all sexual offenses, abuse, sexual exploitation, or even pornography of the children. So therefore there is no right answer, but I would just like to tell you that it is mandatory to report it. You cannot let the patients go, even if they don't want to be treated by you. You must call up the police or the CWC center and inform them, and it is legally binding upon us. Otherwise it will invite a punishment of 6 months for the doctor or a fine. Now, as per the POXO Act, we have to send it to a government or a semi-government institute. But in case such an institute is not available, then any registered medical practitioner can examine the child, but preferably a female should examine the girl child and maybe a surgeon for the male child. Okay, and the thing is it's not only giving the first aid to the child because she's bleeding, you may have to do suturing or whatever, but the thing is you have to gather evidence. So that evidence should not be cleared off. And therefore, there is something like a concept of a safe kit, which I will tell you. So any clinic, nobody can send this child away. If there is no semi-government or government institute, every health worker should know how to deal with this case. You can follow SOPs. There are different guidelines on the website also available. And the safe kit is a sexual assault forensic evidence kit, which is available in the government institute, and these cases are usually seen by the forensic experts. Therefore, the pediatricians never come into the picture and we are less aware about it. So they go to the forensic expert along with a gynac or a surgeon as and when it is required. The safe kit is nothing but it is what is given for these patients, that there is a form of documentation. There's a 10-page form where there's a very detailed examination of the entire body with figures. So it's a human body and you have to exactly point out where is the laceration, how old is it, 72 hours have passed, etc. You have to take samples from the site, like from the pubic area, or there's a comb involved. So you have comb, scissors, nail cutter for scrapings. You have to remove that clothes of the child or the survivor and put it in a cloth bag. You have to seal everything and send to forensics. So there's a change of clothes also for the survivor, along with personal hygiene items. So all these, there are about 25-30 items which are there, and they can all be indigenously prepared in your center. It is nothing that you cannot have it. So if you know the contents of a safe kit, you can keep it in your hospital. Everything has to be sealed, signed by the doctor and the survivor and the guardian, and then it has to be handed over to the police or to take to the forensic expert. So this is a safe kit which has to be present, because you need to document by showing all the things in the form and sending the scrapings or the swabs. Now, emergency drugs, post-exposure prophylaxis, prevention of pregnancy and STDs is other thing that we have to remember. So to prevent pregnancy, levonorgestrel is given, or even the Maladi tablet can be given, 2 tablets start followed by 12 hours later. Then prevention of STDs like HIV, you may have to give post-exposure prophylaxis. You may have to give azithromycin or metronidazole along with it for 5 to 7 days. So these are some of the things that we need to keep. Apart from, if the child is very badly bleeding, then she or he may need suturing and dressing and other aspects of it. So this is one POXO Act which is punishable, and therefore we all should know about it. No per vaginum examination is allowed of the child, and you have to fill all of this in the form. And if below 12 years, then consent by parents or a trustworthy guardian is required.
We have got 10 minutes more left.
Yeah. we've got one case only. So POXO Act is a gender neutral act which a child according to the Juvenile Justice Act or the JJ Act is up to 18 years of age. And every healthcare worker should know about it. Reporting is mandatory. You have to inform the local police or the CWC. Withholding information is a punishable act. Consent for examination within 96 hours of the incidents with documentation, sample collection, sealing and proper handover. Safe kit can be indigenously prepared, and do not forget the psychosocial and mental rehabilitation of the child. This is the most important part which is required after first aid or medical this thing is completed.
Ma'am, in case if it is an accidental injury, and do we still need to report to the police?
How will you verify it's accidental and it's in a genital or private area?
It's a genital area, but accidental and fall. Maybe I had a patient who had a fall from the swing and got hurt.
So you documented like that, but you still nevertheless inform the police.
Ma'am, just thinking practically, I mean documenting or everything is fine, but how can we actually physically make the parents wait there in our OPD with the child, even if we are suspecting a sexual abuse? Yes, in my OPD notes I document, I take a photograph and I will try and call the police.
So you
I
can
don't
take
get
the
through,
details
so
of their parents' contact details and send them to a government or a semi-government hospital.
Exactly, that's what would
But
like to know.
tell the police.
Yeah.
Can I say something?
Even the patient absconds, still you have to inform to the police.
Whatever you said is agreed, but that does not abdicate us our responsibilities. So we have to do it, whether it is whether we're busy or we have to write, whatever. If such things are there, whether it is private, government, corporate, have to be done.
What level has to be done? The safe kit and all that is.
That
And
is
if the parents are just taking the child away, I cannot physically hold them
then
there.
you have to report to police.
So that's what reporting to the police is the
mandatory.
thing, no?
Mandatory.
Your
That is
job is to inform.
mandatory, yeah.
Because if you don't inform, then they
Samir,
don't let you know.
Bolo na. We are
No,
running
I-
out of
I
time.
would
We
just
have
say
one more question.
Yeah, one thing practically, I'm being very practical for all my fraternity. There's one most important thing in this slide. Inform the police. But the very important part is keep a record that you have informed the police. मैंने पुलिस स्टेशन में फ़ोन करके इंस्पेक्टर शिंदे को बात कर दिया. इंस्पेक्टर शिंदे बोला मैं भक्तों का हरकत ना है. बोला मैं छुड़ गया. ऐसा नहीं होता है. I have to record that I have spoken to him or go to the police station or send my assistant and get that pauti. That pauti is very important. And coming back to that question about whether it is a genital injury or... See, there are times when the case is filed without... every time there is a murder, we don't file against... At times it may turn out it's not a murder also. What is important is that the incident is reported and the incident is highly likely to be a sexual abuse. It is our duty to inform the police and keep a copy that we have informed the police. Yeah? Thank you.
Okay, so we go to the last question.
So after COVID, we are seeing this scenario commonly now. So this 12-year-old child with 2-month history of fever and fever cough sputum gene expert is come positive with a rifampicin resistance, and the complete reports are still pending. So what will be your next plan of management? So first is wait until the reports come and then start AKT according to the MDR TB protocol, because you have enough treated the previous this kind of patients. Don't treat the child, refer to them to nearby senior pediatrician. Inform parents about the MDR tuberculosis and first screen all the family members and none of the above. Please start voting. Start voting. Many of us are seeing this kind of scenario after post-COVID. So let's discuss now. So I think this is 50% chance of wait
So
until our reports come
40%.
and inform the parents about the MDR TB.
Okay.
So ma'am,
The priority here would be, you know that it is already RIFA resistant. So you start the drugs as per the MDR protocol without the rifamycin and you wait for all the other tests to come. Yes, it is important to inform the parents and start screening the family members. And also, if you do not have the facilities, you can always refer to the nearest government or center which has a state excellence for TB. So actually this is not, any of them are not a complete answer, and here it is that each and every doctor has to register that patient on the NICSHARE portal. So this, according from the year 2018, it has become mandatory to report all cases of tuberculosis, whether drug sensitive or drug resistant, by the treating doctor, the chemist, the pharmacist, etc. And the benefits are a lot many for the patient as well as for the doctor, who informs and gets monetary incentives in the form of money at the time of informing at the end of treatment. So once you know the details about the NICSHARE portal, so it is a integrated information and communication technology which is real time, it is web based, case based, and it is used as a surveillance tool. So when you put the NICSHARE ID of the patient, you get all the details on your mobile phone. So you have to inform either by using the NICSHARE Sampark helpline 1800 11 6666. You can download the app on your mobile and do it by a web portal, or all the hard copies are to be submitted to the DTOs. There are various incentives given by the government for the patient, wherein there are even lab tests offered free of cost, like gene expert, microscopy, you have drug sensitivity culture, and also LPA. Or in a private setup, they will be subsidized or reimbursed also. So this has to be known to the patient. Plus, if they have an Aadhaar card, then their account is, bank account is linked with the Aadhaar card and NICSHARE number. They get that a direct benefit of transfer of money till the time the treatment is over. So even up to 2 years for MDR TB, they get 500 rupees or 750 rupees in the tribal area. So these are the things that we have to know as treating doctors, that we will start the MDR treatment as per the NTP guidelines. Refer to the state MDR TB center for further investigations if culture sensitivity, because you have to send it upfront nowadays, and offer them all the benefits that are there. Mandatory to screen all the family members and contacts. Treat the contacts if they're having active TB, or give them prophylaxis if there is no active TB. Counsel the parents and patients to adhere to the treatment and complete the treatment. So NICSHARE is TB Mukt Bharat. Okay, Share Mukt Bharat. So we are aiming at elimination of TB now. And this is about the NICSHARE. So it is a program which has been started by the Government of India and Central TB Division. So each one of us should know about this. So what is notifiable in India? One, we have already told POXO is compulsory, or it will invite a fine or imprisonment. All suspected and confirmed TB cases, they come under the IPC Act 269, which is Act of Omission or a Negligent Act, and the IPC 270, which is Act of Commission or a Malignant Act. So though they are to be compulsorily informed, there is no known punishment as of now. We have not heard that anyone has been punished, but I don't know what punishment it's likely to be inviting. But all suspected and confirmed cases of TB, all cases of acute flaccid paralysis, including facial palsy and viral myositis, all cases of fever with rash, and all vector-borne diseases. So we know that, and this is what is notifiable in India. Thank you.
Thank you very much, madam. So we are now going to announce the winners for the oral paper presentation and the posters. So I call upon Dr. Bela Verma, madam, stay there. Madam, stay there. Dr. Sushant Mane and Dr. Sushma. They are the coordinators for the oral papers and posters.
We will call the judges now.
I think the matter of, excuse me, the matter of treating TB at your clinic, I think it's an important aspect. Well, normal TB, of course, there's no question, we are all very well trained. MDR and XDR or pre-XDR are the ones which are questionable. So, I mean, we had a debate and Sushant came to our help that according to Sushant's written mail to the Mumbai district TB officer is that any qualified pediatrician can actually treat an MDR TB. But he says preferable that you undertake the IAP module on TB, which also covers the MDR TB. And question come about bedaquiline. It's a drug which can be given only under certain centers. So Hinduja is one center where we can give bedaquiline, but funnily that prescription has to be signed by a pulmonologist. So I wrote a question that if I have a 8-year-old who is eligible for bedaquiline and has say neurotuberculosis, what has the pulmonologist to do with a child who is 8 years in a neurotuberculosis? So that's where a lot of mails went forward from my hospital through the DTO to Sushant, and that's where he said that even bedaquiline can be prescribed by a qualified pediatrician, but preferred that you undertake the IAP TB model. So I would earnestly appeal all of you, at least if not undertake a formal training, at least have that PowerPoint. It's available freely in a read-only formula, excellent presentation, and every time refer to it because MDR TBs are not easy to treat. Having said that, you can treat if you're confident. Once you treat 5-6 patients, it's easy. Otherwise, you refer to Sushant, he will give the medicine, he will send the patient back to you. And believe me, that happens.
So we are having the NTEP workshop in Borivali on the 9th of October on Sunday. Anyone would like to give their names, please give to Nilesh and Vinod. So anyone close staying to Borivali can join. Sir, we'll discuss it.
Yeah. Yeah. Okay. We wish to announce the prizes for poster presentation and oral presentation. So first, we would like to start with the oral presentation, oral papers. For the oral papers, we had judges, Dr. Mamta Manglani Madam and Dr. Sandeep Baudekar. May I request Madam and Sir to come on the stage, please.
He's there. Yeah, he's there.
So the first prize goes to Dr. Aditi Gupta and her paper titled A Study of Barriers to Prenatal Testing of a Genetic Disease in Children. She's from KM Hospital. And the second prize, the second prize goes to Dr. Saurabh Gade.
So we had actually 3 entries, but one did not come. So we have given 2 prizes. The first prize is cash prize of 5,000 rupees, and the second prize is cash prize of 3,000. That will be transferred directly to the bank account.
That will be get transferred directly to your bank account. So kindly get in touch with Mr. Nilesh Poti. Yeah.
And posters, we have 3 prizes. First prize is 3,000, second is 2,000, and the third one is 1,000 rupees.
Yeah.
Second prize is for?
Dr. Saurabh Gade.
He's from which institute?
He's from KM Hospital. So I
you
request
can take-
Aditi to take his certificate.
Posters.
Thank you, madam, and thank you,
Thank you,
Baudekar,
ma'am.
sir. For the posters, we had judges, Dr. Prashant Gangal, Dr. Sanjay Prabhu, and Dr. Meenaz Sheikh, sir. May I request all 3 of you to come on the stage, please? Thank you. Yes, sir. Sir, Rajesh Chok. Requesting Dr. Rajesh Chokhani, sir, and Nehal, please come on the dais. Yeah. And Amruta, sir, yeah. So the first prize goes to Dr. Soumya Jain. She's from KM Hospital. The second prize goes to... Okay. So the first prize, Dr. Soumya Jain, title of the paper was Disseminated Tuberculosis with Hemophagocytic Lymphocytosis in a case of a severe combined immunodeficiency.
I mean, it was really well worked up, and the girl was excellent in her presentation. She was knowing all what was into it. That was the beauty of this. I think came. So she deserved it.
Second prize goes to Dr. Manasi Manwar, and she's from BJ Wadia Hospital. Her paper title was Case Report, Rare Case of a Mendelian Susceptibility to Mycobacterial Diseases.
No.
Okay. And the third prize goes to Dr. Vipul Jaju. His paper was on methemoglobinemia in infant with acute gastroenteritis with severe dehydration and sepsis, 2 case reports. Acquired. Thank you.
So we
I must
now
tell one
break
thing
for
only.
tea.
For awesome 42 posters.
Yeah.
42 posters. Judging were difficult. All were 46. Yeah.
No, total were 52 papers, out of which 49 were posters and 3 were oral papers. Yeah.
And judging them were difficult. All were at par. This is only somebody is little better than others. So all were excellent. That's the message.
So, so all these students also, you can make poster presentations and oral papers for the IPA Congress, which we have, the National Pedicon 2023 February at Ahmedabad. So start thinking and preparing and send for that. Now, yes, sir. IAP Mumbai. Right. So October is the last date for the entries, and now we quickly break for tea, 15 minutes. It's 4:25, so we meet again at 4:40. Next interesting sessions. Sir, Ajut Ron.